There I am.
There you are. Sorry, I kicked you off there. That was my fault.
I thought I did something. I was like, uh-oh.
No, we're having difficulty running the two at a time. So
I thought maybe it said I was in a different meeting, so I wondered if it was something like that.
yeah, so I'm just working on getting that taken care of real quick. But
Okay.
you guys can go ahead with the congenital discussion, and then the coping one I'll take care of.
Okay. I'll just talk a little bit. I'm not sure where I get caught. We were talking about the recombinant ADAMTS13 study in congenital TTP, I think.
Correct.
So the phase 3 is an ongoing study. It's a randomized study where patients get either standard plasma infusion or the recombinant for 6 months. Then they're switched. They switch arms of the study. It's underway. There's not much we can really say about that. There are patients being treated, I think, Satheesh at Emory as well, correct? And Ohio State?
Correct.
But at least the data from the phase 1/2 study were very interesting and showed that the drug seems to do what it's supposed to, in short, really. It's supposed to restore this protease function. You get the ADAMTS activity level back, but you also get this cleaving of those ultra-large multimers that we're expecting to see. So the numbers look good, and the functional part of what it's supposed to do looks good from the first study. Satheesh, go ahead and add your insight.
No, I think that's exactly the case. Actually, the trial is actually handled by Dr. Antoon from the adult perspective, not actually open on the children's side of it. But
Gotcha.
I think you're right. There is another question which came through earlier, it's a two-part question. I'll see if you want to take the first one. I can take the second part.
Sure.
Any evidence of caplacizumab helping congenital TTP patients avoid plasma and maintain high platelet count? Yeah.
I could take the first part. You do the second part?
Yeah, the second part, which is the same question on rituximab and CoV-8.
Certainly. So the rationale for why caplacizumab would work in acquired or immune-mediated TTP is still there in congenital TTP. It blocks the formation of the microthrombi. In the immune-mediated, though, you're eventually going to use immune suppressive therapy to get rid of the antibodies causing the problem and taper the drug. In theory, could you take caplacizumab continuously? In theory, yes. It's not indicated, right? There's not been any studies done in that population. And there's a small bleeding risk associated with it. So theoretically, is it possible it would work? Yes. Is it been studied? No. Is it something that can be done? Not at this time.
So the second part of the question is the same thing for rituximab and CoV-8. So rituximab, as you know, it kind of wipes out the B cells, which would make the antibodies. So certainly it's used for acquired or immune-mediated TTP. It's not really a treatment used in congenital TTP where there's actually absence of ADAMTS13, and it's absence because they have a genetic mutation, so they're not making ADAMTS13. CoV-8 is actually a very interesting question. CoV-8 is a product which has factor VIII, which is a clotting factor used in patients with hemophilia A. And the same product also has some ADAMTS13 in it. So certainly it can and use. So the two different products in the US, it's CoV-8. The one in UK is called, or England is called BPL. There's a lot of data on BPL. A recent paper actually talked about how it is used, especially in their younger adult population who get this sort of prophylactic treatment. Going back to your real question, can we use this CoV-8? So CoV-8 is actually, after a dose of CoV-8, the ADAMTS13 comes back to baseline in about 6 days. So hence it has to be given a little bit more frequently in patients who need it for prophylaxis or need it as an acute therapy. It's certainly a smaller volume. So you can potentially do a lot of home therapy in younger children compared to adults. Has a lesser risk of allergic reactions compared to regular plasma treatments. So certainly it is, you can avoid plasma, but as I mentioned, it has some differences to an actual plasma infusion for congenital TTP. And whereas the BPL, I don't think it's available in this country. It's actually used mostly in the United Kingdom, works kind of very similarly to CoV-8.
Very good. Maybe I'll take the next question. Is there a difference in how ATTP or ITTP and CTTP affect the brain? It's a good question. I think there is we're still early in the understanding of how immune TTP patients affects the brain, both acutely and chronically. I think acutely you could see the same thing in a congenital TTP as you do ITTP. In theory, the ITTP would be more acute, the immune-mediated. The congenital may not be as acute, but more subacute, but that doesn't absolutely hold. I think the bigger question is long-term. We do see some of these neurocognitive deficits in the patients with the immune-mediated TTP. We're still not absolutely clear how that happens. One possibility is lower levels of ADAM-TS13 could contribute to these deficits. If that's the case, it may be possible that we're going to see similar things in congenital patients. There have been some reports of, and Satheesh may be able to help more I can on this, but there have been some reports of chronic vascular issues in patients, in the adults I've seen as well.
Spero, if I could interrupt you just for 1 second. I wanted to let everyone on here know, if you were trying to get into the other session, the coping with chronic illness session, I put a new link in the chat. And if you email admin@USTMA.com, I can send it to you that way as well. You'll have to use that new link, and it'll be the same thing for the Ask the Hematologist, which I'll create a new link for as well and send that out. Thank you.
Thanks, Claire.
Thank you. I'm not sure where we are with the next question.
Let's see. Impact on brain function, how would it be diagnosed, identified?
Sure. If you suspect there may be some impact on brain function, how is this diagnosed and identified? I think, this goes back into some of the nice work that Dr. Chaturvedi has done from Hopkins. So it's still a lot to learn in terms of the impact on brain function. And the two larger groups have reported, one from the International Registry, another one from UK, about their experience in patients with congenital TTP. Certainly stroke is an important complication seen in these patients, but more so it's important is that the silent infarct. So these patients may actually have what's called as a subclinical infarct. So they might have no symptoms with it, but when we do an MRI, they may pick up features consistent with small infarcts. So certainly in terms of diagnosis, I think at this point, a good history, neuropsychological evaluations are key, and also an MRI brain, and certainly done in places and also read by neuroradiologists who's kind of used to looking at these subtle changes. And Dr. Jim George recently also compared it to patients with sickle cell disease who actually tend to have a very similar silent infarcts. So hence it has to be more of a multidisciplinary management and a routine follow-up with some of these patients.
Go ahead, Claire. You going to handle that? Was that you, Claire? Maybe not. Well, there's a question. I don't want to step on her toes. There's a question coming that I'll handle. Then I'll hand them out to us here that are coming in.
Sure.
Try to.
Okay.
Good question. I was recently diagnosed during pregnancy and I asked my doctor if I had ATTP or CTTP. They were sure it was ATTP because I have no family history. It's not an easy thing to differentiate the two. That's not really a great way of doing it. This is an autosomal recessive disease, which means you have to get the genetic mutation one from each parent. So it's certainly possible it could be in the bloodlines and nobody sort of has had the disease or knows about it, or it was just misdiagnosed as something else. The better way is looking for an inhibitor, which is some testing that can be done, and looking for the antibody itself. I don't want to get too technical in this session, but there are ways of doing it. But as I talked about earlier, a new presentation during pregnancy should raise your suspicion for a congenital form of TTP. An even simple way of doing it is rechecking your ADAM-TS13 activity after you've recovered. If it stays low, if it goes up after your initial treatment and goes down low, that might be suggestive of of a congenital form. You have to sort of have some understanding of the ADAM-TS13 activity, half-life, and when you're measuring it in the context of when it was infused. So I don't want to get too technical, but just saying no family history, it's not congenital, probably isn't the best way of doing it. Let's see, Satheesh, here's a good question. I just saw it. So what is your normal treatment protocol for congenital TTP in normal times once an exacerbation has subsided? So the treatment for congenital TTP.
Yeah, I think it's a great question. There's certainly some variability in how it's done in different parts of the world and also between different providers. The important caveats to take from this is one, if they're having symptoms, and I think that's very important because which has shown that they may not have any overt symptoms. So you can start treatment just for having low platelets, or you could have symptoms such as lethargy, headaches, or tiredness, some of the symptoms why people start treatments on. So certainly if there are any of these treatments, recommended is to start what's called as a prophylactic or to prevent the major episodes. And some of the registry information or data has shown that treating patients with just these symptoms alone, with having even normal platelet count, they've actually had resolution of symptoms when they were given frequent infusions of plasma or one of the other products that we recently or briefly discussed. In terms of exacerbation, there's clearly, when there's a suspected exacerbation, very important to ensure that treatment such as a plasma infusion be immediately be given and followed closely. And also at that point of time, it's important to discuss what, from each patient in terms of the risk-benefit ratio. Is there a patient who has a higher risk of having those exacerbations? Was it exacerbation during infections or pregnancy? So there are certain conditions which can certainly increase the risk of having symptoms with low platelet count. And again, regular follow-ups with the hematologist, and also looking at long-term end organ damage is also important, looking at the kidney function, the brain function, and so on. So at this point, there's really not straightforward guidelines like we have for acquired TTP. So I think it's, we hope to do further clinical trials to help understand these prospectively, as in plan ahead and then follow these patients forward. And again, since these are very rare, even rarer than acquired TTP, it does require a more of an international collaboration to do such testing and learn from it.
The next question, we'll split it up and I'll take the first one. So what might be the long-term implications of receiving so much plasma over the past 30 years? Certainly the short-term issues with plasma can be the volume overload. It can be a large volume load and can be sort of difficult to handle physiologically for some patients with blood pressure issues and shortness of breath. That's a relatively short-term issue, and it doesn't really, it's not a cumulative effect, as your body will sort of deal with the extra volume and you'll pass it out. There's always the infectious concerns, but I think the blood supply is felt to be safe. There's testing. And although that risk is not zero for infectious pathogens, I think the risk is a lot lower than it was. I think the blood supply is safe, I would say. Mm-hmm. And Satheesh, I'd say this is for you. Since the ADAM-TS13 is still low, even when we get plasma every 2 weeks, are we at higher risk for stroke, et cetera?
Yeah. So after plasma infusion, a typical plasma infusion, I think the ADAM-TS13 kind of goes back to baseline in about like 5 to 10 days. So certainly people who start patients on prophylactic plasma infusions are given about every 2 to 3 weeks or more frequently if they have symptoms. So your question is, are we at higher risk for strokes? I think it's a great point. I think at this point, we do not know at what level of ADAM-TS13 will prevent such strokes. We're not sure if having normal platelet count, but still having low ADAM-TS13 will still put them at a higher risk of stroke, because we expect that we talked earlier about this little blood clots that could form, which could actually contribute to some of this abnormal brain function. So unfortunately, I can't give a very straightforward answer to that, but I think it's important to discuss this with each patient in mind. and look at their future to see what are the potential triggering factors that they may encounter and act accordingly. Any other thoughts from you, Spero?
It's tough. It's a good question. We know your Adam TS levels are going to 13 levels will be highest right after you get it. They're going to be lowest when you come back in for your next one at 2 or 3 weeks. And the difficulty is we really don't know how much Adam TS13 is in each unit of FFP that each unit of plasma they might get, and that's going to vary from infusion to infusion. So it's a bit difficult to know, and I think that may be one of the benefits of a recombinant Adam TS13. You can control better the dose, and assuming there's no issues with clearing of it from the immune system, antibodies against it, you'll have a good idea how long it will last, so you can sort of plan their visits and their infusions based upon the Adam TS13 activity. We try to do it now, but it's kind of a balance of the lowest Adam TS13 activity after the infusion, 2 weeks or 3 weeks, and how often they want to or can come in for infusions. It's not an easy question.
Great question.
Let me see. I think Satheesh is the next one for you. Our 3-year-old daughter has congenital TTP and continues to struggle with keeping her hemoglobin up between episodes. She takes iron twice a day, and as her iron gets low during that time. Is there anything else that's been done to manage that symptom? She does the coate 2 times a week also. So iron deficiency, anemia, and congenital TTP.
Yeah, it's a great question. A 3-year-old, a toddler is one of the age groups that iron deficiency is very high. It's thought that almost 50% of them may be actually iron deficient in United States. Not everybody will be anemic from it. So I think it's actually a bigger problem, just iron deficiency separately, when you put this an additional challenge of congenital TTP. Certainly that I can see the challenge with being able to keep the hemoglobin up in between these episodes. I would recommend the child does get a very good evaluation, looking at the nutritional aspects of it. It's not just the iron, which can also contribute to low hemoglobin. There are various other reasons that any child could be anemic or have difficulty keeping up the hemoglobin, to ensure there's no any blood loss from anywhere. And that's actually not an uncommon thing, even in a toddler. So sometimes more of a closer and a rigorous workup is needed to ensure there are no other reasons for anemia, and it's just because that she's breaking down red cells from congenital TTP. If that is truly the case, once we have ruled everything out, then we have to sit and discuss, is coate twice a week would be sufficient? As mentioned earlier, after the dose is given, I think by about 6 days or so, it's back to baseline. So hence, as you can see, looks like you're giving twice a week or once every 2 weeks. It's not clear. But something discussed to see, is that the right product, or do you have to try something else? Do you have to do it more frequently? The dose is also important. So I'm not sure the dose that your child is receiving. So hence, I think it's important to go back to the drawing board, look at all the causes of anemia, and then come up with a strategy for your child.
Satheesh, along those same lines, I would ask you a question. So I understand that coate could be administered at home, which is important for a child, versus plasma that may have more Adam TS13 activity, but has to be given in a clinic. Does that factor in your decision, your discussions with younger children especially, and how do you typically handle that?
No, I think it's a great question. Again, all of us have very minimal experience in terms of following these patients. They're usually in single digits in terms of the number of patients we manage. With that caveat, I think many of the patients are okay to come to the hospital for plasma infusions, as long as we can have a very swift way of bringing them in and getting them home quickly. And so we've been lucky in doing that. But certainly if they live very far away, that still can be managed, but have a local hematologist or pediatrician who's comfortable doing this, and then still they have a very close contact with the hematologist in the nearby referral center. If certainly coate is a product it's used, is cheaper, and a lot of other beneficial effects of coate too, and if it's a discussion of the family and the physician feels it's the right thing to do, it can be done at home. But I think it may also require more frequent monitoring of hemoglobin, platelet count, and symptoms, especially in a 3-year-old. You want to also ensure that the patient is growing properly not just physically, but more from a mentally and from a growth development standpoint. Yeah.
There was a question earlier regarding gene therapy in congenital TTP. What are your thoughts on that? I don't believe there's any studies along these lines.
Yeah, it's a great question, especially so gene therapy. Briefly, it's a technique where we manipulate the gene. If there's a defective gene, you can actually give it more of that gene or replace the gene which is defective. As of now, my understanding is that all the studies are done in mouse models of deficient ADAMTS13. They've used various ways of getting the gene being produced more in the mouse, but certainly I don't think it has been tried in any human studies yet. We're not there. Having said that, as you probably all know, hematology is going through a major revolution in gene therapy, and the technologies that's been looked at for patients with hemophilia and various other blood disorders will certainly be brought into this field. It's no way for me to know how long that's going to take, but it's exciting.
Satheesh, I'll give you another question. You might be biased on the answer, but let's see. So do you think it's important for congenital TTP patients to somehow be tied in with a university or research type medical practice that can provide oversight for care, especially if one lives in a rural outlying setting with only basic care available, only biweekly FFP infusions? That's a loaded question to a guy.
I think it's a great question. So personal experience, I was in Ohio, not where Dr. Cataland was, and now in Georgia, we do have patients coming within Georgia. They travel sometimes 2 to 3 hours to get here, not taking into the consideration of traffic, but we have patients coming from neighboring states, hence we end up having a larger populations of these patients. It's a challenge for many of these patients who want to have a fairly normal life with these patients. So I still think it's certainly possible, especially with the telemedicine. One of the silver lining of COVID has certainly improved being able to communicate with these families much more frequently than what I ever did, to be honest, for various rare blood disorders. So I think I can tell you the very few pediatric hematologists have ever seen a patient with TTP. So with that in mind, the very few pediatric hematologists who are comfortable managing these patients on a long-term basis. So I strongly think for these reasons, it's still reasonable to have some kind of a contact, either nearby hospital or somebody even outside state, to maybe see them at least once a year. But important is that the local physician should be in touch. That's what really matters mostly, at least with the referring or with the provider at the university hospital, I think.
I agree. I think it's important to have both physician and patient have you as a resource if needed. Here's an interesting question, so I'm going to try to summarize it. It's the patient whose father had an autoimmune factor VIII deficiency, so probably what we call an acquired factor VIII inhibitor. And then she was diagnosed with the acquired TTP at age 59, and she was told there was, I think it's a she, I apologize if I missed it. Oh, it is. Glad I got that right. She was told there's no hereditary link to the TTP and her father's episode. Her ADAM-TS was low at that time, and she had not had a repeat value since. So I think certainly, I mean, this is not a congenital form of TTP. It's a good question. This is an acquired or immune-mediated TTP. And although there's not a clear link in those hereditary-wise, we certainly know that there can be a family history of autoimmune diseases. And we know if a patient gets one autoimmune disease, you're more likely to get another. So certainly there could be something about your bloodline that makes you more likely to develop an autoimmune disease. Your father, it was his factor VIII, he developed an antibody. In your case, it was the ADAM-TS13 protease that you developed an antibody. So directly related, no, but there may be something about your bloodline where autoimmune diseases may be more common or more likely to occur, as those are both obviously very rare disorders. See, Satheesh, I have a question for you.
Yes.
So it looks like it was a follow-up question from before that a patient has never come up to 3.0, never come up above 12%, averages 8% activity, and she goes back to baseline after 2 days. Is there hope that recombinant will bring that level higher or keep it there longer?
Yeah, I mean,
Is actually there are patients that, TTP seems like such an acute, obviously serious presenting disorder, whether it's immune mediated or congenital. It should be this acute storm. But there are people who can limp into this. And I remember a story told me by one of the experts in the world in Boston in ITP. So a different disorder. This is the antibody attacks your platelets. You have a low platelet count, more of a bleeding risk. And in their referral center of patients with refractory ITP, they will regularly and routinely find patients who have low ADAM TS13 activity and could be acquired and immune mediated or potentially even a congenital TTP. I think there's a greater awareness for the diagnosis of congenital TTP, especially amongst pediatricians now. But they can certainly sort of sneak through the system, if you will.
Yeah.
Let's see. All right, this is just, okay, clarifying on an earlier question. I've been diagnosed and looking back to 3.5 years old, diagnosed with TTP during pregnancy at 23, and am now 56 with several exacerbations over my life, typically occurring with the onset of flu every 3 to 5 years. Once testing was developed, it was verified that I have congenital TTP. My levels are watched. I get FFP if needed, but do not take drugs or any other treatment normally. I think this is a good example of someone who could sort of sneak through and presumed because maybe the intermittent episodes, maybe they weren't so severe. But you can go through life with enough ADAM TS13 activity, 8, 10%, 12% as your baseline, and you're okay for a normal life. But something happens, pregnancy and infection, some of those triggers that you mentioned there, and it can lead to an acute episode. And again, it should be very easy in theory to tell the difference between acquired or immune mediated and congenital, but it may not be. One of the other clues is people, when you're treating TTP with plasma exchange, you're removing antibodies and you're adding back the protease. And it's sort of like bailing out a boat. It's a slow but steady process. These congenital patients will typically get better really quickly on plasma exchange, quicker than they should. And that sometimes gets people's attention. Satheesh, what do you think about that? Getting into age, your 50s. Good physician to pick that up.
So she was diagnosed at 3.5 years of age.
Well, I think looking back, I think by reading correctly, looking back, her first episode was 3.5 years old.
Okay. Yeah, that's very interesting because the British data was very similar, that they had 2 peaks of diagnosis. One, toddler years, around median of 3 to 4 years of age, and the second peak was adulthood. Most of them were during pregnancy.
Yeah.
And I think so you certainly kind of fit with that. As mentioned earlier, there's certain trigger points, certainly the newborns where they have jaundice or severe jaundice needing exchange transfusion, where we try to minimize the jaundice affecting the brain in the baby setting. And then they can present sometimes later on or never till they're pregnant, or sometimes even many years later. So that's interesting, and the challenging aspects of congenital TTP.
Well, hang on. When new questions come in, it jumps my screen down and it confuses my simple mind. One interesting point, though, now she's now 56, and she had her first sort of as an adult presentation during pregnancy at 23. So that'd be 33 years ago, and that predates the discovery of the protease. So they would have no access to ADAM TS13 testing, and the fact that you would present as an adult with a TTP picture, that certainly makes sense why they would sort of presume. The clue would have been that you got better much quicker, but that may not have been common knowledge back then. And that's really getting to be right around the time that plasma exchange is really, it's been there for a few years, but really in earnest being used and utilized in patients.
All right, sorry to cut you guys off, but we are at time here.
Oh.
So if you give me just one moment. Thank you guys for doing that, and we'll keep the chat and the questions to be able to do more with. I am going to promote Joanne to a panelist here so she can give us a little background on herself, and then I'll pull up her slides. Just give me one moment.
Great. Thank you, Satheesh. That was great.
Thanks, Spero. Thanks, Claire.